Good afternoon, everyone. Today I'm speaking on behalf of patients who undergo cosmetic rhinoplasty here in Queensland. This group is especially vulnerable. Many are young, shaped by social pressures and body image concerns, and they rely heavily on doctors to tell them the truth before agreeing to surgery. Now, rhinoplasty is one of the most common cosmetic operations in Australia, but it's also one of the riskiest ones. Studies and reviews show complication rates are significant. Things like scarring, asymmetry, infection, breathing problems. And when a rhinoplasty goes wrong, the damage is not just physical. Patients often experience depression, anxiety, and a real loss of confidence. Unlike therapeutic medicine, cosmetic procedures are elective. There is no medical necessity driving the decision. It's usually aesthetics or psychology that makes disclosure even more important. The High Court in Rogers and Whittaker told us that doctors have a patient-centered duty to warn. Even rare risk must be explained if they could matter to the patient's choice. And in cosmetic surgery, the threshold is particularly high because patients are often less able to separate what's necessary from what's risky. In independent review of the regulation of medical practitioners, it says many people choosing these procedures for young women, some with body dysmorphic disorder, that makes them especially vulnerable to misleading advertising and unrealistic promises. The Medical Board of Australia has tried to step in with things like cooling off periods and tougher advertising rules, but as the inquiry showed, there are still big gaps. So, where does Queensland law stand? Under the Civil Liability Act 2003 and common law, there is some protection, but it's not enough. Most negligence cases in cosmetic surgery don't come from outright surgical incompetence. They come from failures of communication, poor pre-operative assessment, no warning about material risk or alternatives, and very little transparency around revision rates. These failures undermine the very idea of informed consent. That's why in this presentation, I will be looking at reforms. Things like mandatory psychological screening so that patients with body dysmorphic disorder are properly assessed. Greater transparency around outcomes and complication rates using simulation and virtual reality to help patients actually understand what might happen. And maybe even a no-fault scheme like New Zealand's Accident Compensation Corporation to make sure injured patients aren't left on their own. Taking together, these changes could close the gap between what the law says in theory and what patients actually experience in practice. They'll restore informed consent as a real safeguard and give cosmetic rhinoplasty patients the level of protection they need and deserve. Now I'm gonna move into the background and context of negligence in cosmetic rhinoplasty. This section is really important because it helps us understand not only the medical aspects of the procedures, but also the social, cultural, and psychological factors that make this area of law so complex. Let's look closely at the background and context of negligence in cosmetic rhinoplasty. First, age. The numbers show rhinoplasty is very much a procedure for young people. In 2020, there were about 44,600 nose jobs in the 13 to 19 age group, making it the top cosmetic surgery for teenagers. That's worrying because teenagers are still shaping their identity and decision-making skills. They are heavily influenced by Instagram, TikTok, friends, and beauty filters. Many don't yet have the maturity to balance long-term medical risk against short-term appearance goals. If doctors or clinics don't explain the risks clearly, it is very easy for these patients to be misled or to regret their choice later. The demand is even stronger in the next bracket. Among 20 to 29 years old, there were more than 110,000 rhinoplasties in 2020. This is the peak group. At this stage, people often connect their looks with career opportunities, relationships, and social life. They also usually have their own money to spend, so surgery becomes more accessible. But having money doesn't mean that they can get better information. In fact, expectation in this age group can be especially high, and if those expectations aren't met, the disappointment can be severe, sometimes leading to anxiety, depression, or the decision to undergo a second surgery. Second, gender. The data shows a clear gender pattern. 82% of rhinoplasty patients are women. Only 18% are men. This gap is important. It shows that women carry most of the pressure to look a certain way, and they also carry most of the risk when surgery goes wrong. Negligence in cosmetic surgery is not gender neutral. It falls hardest on women. From a legal and policy point of view, that makes this area especially sensitive. Third, ethnicity. If you look at all cosmetic procedures in 2020, the breakdown is 66% Caucasian, 13% Hispanic, 11% African American, 8% Asian American, and 2% other groups. Rhinoplasty cuts across all of these categories. What this tells us is that beauty standards are no longer limited to one culture. Global social media spreads the same narrow ideals everywhere. So patients from many different backgrounds are now seeking surgery, sometimes not because they need it, but because they feel pressure to conform. That adds another layer of vulnerability. Fourth, patient behavior. To statistics here are especially important. 44% of cosmetic patients are repeat patients, and 57% undergo multiple procedures at the same time. Rhinoplasty is one of the main surgeries people repeat, because if the first result isn't what they wanted, they often go back. But revision rhinoplasty is much riskier than the first surgery. There is more scarring and the anatomy is harder to work with, and complications are more likely. That means a weak consent process doesn't just cause one problem. It can set off a cycle where patients keep returning each time facing bigger risk. Fifth, settings. The statistics also show where cosmetic surgeries take place. Around 37% happen in office clinics, 18% in hospitals, and 45% in freestanding surgical centers. This matters because the level of oversight and safety can vary. A hospital setting usually has stronger safeguards, while an office clinic might not have the same resources for emergencies. If patients aren't told clearly about these differences, they may not realize the extra risk they are taking. When I put all these together, a strong pattern emerges. Rhinoplasty is most common among young people, especially teens and those in their 20s. It is much more common for women who already face higher appearance pressure. It crosses cultural boundaries, reflecting globalized beauty standards. It's often repeated, with revision surgeries carrying greater risks, and it's delivered in different clinical settings with varying safety standards. This combination of youth, Gender pressure, cultural pressure, repeat surgery, and mixed clinical settings create a high risk environment. Most negligence cases in cosmetic surgery don't come from gross surgical incompetence. They come from communication failures, not enough preoperative assessment, non warning about rare but serious risks, not explaining alternatives, or overselling benefits. Policymakers have recognized this. The 2022 independent review of cosmetic surgery by Australian Health Practitioner Regulation Agency and the Medical Board of Australia found that many cosmetic patients are young women, often struggling with body dysmorphic disorder or anxiety. It recommended stronger safeguards, including mandatory psychological assessment and tighter rules and advertising. That shows the vulnerabilities we see in the data are not just hypothetical, they are documented and serious. So, the background and context tell us this. Rhinoplasty is not just an individual choice, it's a social phenomenon. Patients are often too young, too pressured, or too vulnerable to give truly informed consent unless the law requires better safeguards. Without stronger disclosure duties, psychological screening, and more transparency about outcomes, negligence will keep happening, not as an accident, but as the predictable result of a system that doesn't adequately protect its most vulnerable patients. In Australia, surgeons owe a duty of care to their patients, and this is especially important in cosmetic surgery like rhinoplasty. The High Court case Rogers v. Taker made it clear that doctors must warn patients about material risks, even rare ones, if they are relevant to the patient's decisions. This case rejected the old Bolam approach and instead adopted the patient-centered duty of disclosure. The Civil Liability Act 2003, Section 21, Subsection 1 sets out how this duty works. Under Section 21, Subsection 1, Paragraph A, there is a proactive duty, meaning that doctors must inform patients about material risks without being asked. For example, before rhinoplasty, the surgeons must explain risks like breathing difficulties, carrying, or psychological impacts. Section 21, Subsection 1, Paragraph B creates a reactive duty. If a patient asks questions about outcomes or risks, the doctor must respond fully and honestly. So if a patient asks whether surgery could worsen anxiety or body dysmorphic disorder, the surgeon has a clear duty to answer. This raises an important question for rhinoplasty. Should a psychological assessment be considered an essential part of providing reasonable care? When courts face novel duty of care questions, two key approaches are used. First, reasonable foreseeability and the salient features test. Both are highly relevant in cosmetic surgery. Reasonable foreseeability asks whether harm to the patient was something a reasonable surgeon would anticipate. The salient features test looks at the relationship between doctor and patient more deeply. Issues like vulnerability, reliance, and control. Rhinoplasty, being an elective surgery with psychological risks, fits squarely into both these tests. The test here is objective. Would a reasonable person in the position of the surgeon foresee harm? As seen in Chapman and Hurst, foreseeability doesn't require predicting the exact harm, just recognizing that some harm is likely. In rhinoplasty, a reasonable surgeon could foresee that if psychological assessments are skipped, undiagnosed conditions such as body dysmorphic disorder or anxiety may worsen after surgery. So it is not far-fetched to expect psychological harm if precautions are not taken. The salient features test breaks duty of care into factors. First, the nature of the harm. Surgeries directly affect a patient's mental health, as highlighted in Roger and Whittaker. Second, reliance on the defendant. Patients with BDD or anxiety place heavily trust in their surgeon, similar to FNR. Third, control. Only surgeons can order psychological or the other requirement assessment before surgery, as seen in Chapel and Hart. Finally, assumption of responsibility. If the surgeon skips proper checks, foreseeable harm may result, just like the reasoning in Wallace and Cam. A breach occurs if the surgeon fails to meet the standard of reasonable care. Examples include inadequate preoperative assessments, poor surgical technique, or insufficient disclosure of risk and alternatives. Cases illustrate this. Mills and Ferguson for failing to meet professional standards. Nahakis and Western General Hospital for inadequate assessment. White House and Jordan for surgical technique, and Wallace and Camp for insufficient disclosure. All of these principles apply directly to negligence in rhinoplasty. Risk in negligence must be both foreseeable and not insignificant. Under Section 9 of the Civil Liability Act in Yorkshire and Shirt, the High Court explained that a foreseeable risk is one that is not far-fetched or fanciful. A risk is not insignificant if there is a real probability of it occurring. For rhinoplasty, risks like infection, scarring, or psychological harm are clearly foreseeable and significant, so surgeons must take steps to reduce them. The question is, would a reasonable person have taken precautions? Section 9, subsection 2 lists 4 factors. First, the probability of harm if care was not taken. Second, the likely seriousness of the harm. Third, the burden of taking precautions. And fourth, the social utility of the activity. In rhinoplasty, the precautions like pre-surgery assessments are relatively low cost, while the potential harm is very serious. So reasonable surgeons must take those precautions. These images show the real risk of rhinoplasty. While many patients expect improved aesthetics, the outcomes can sometimes include deformities, infections, and tissue necrosis. These examples highlight why clear disclosure of risks and through preoperative assessments are essential. Cosmetic surgery is not medically necessary, so any failure in communication or care can leave patients with both physical and psychological harm. The tragic case from Turkey highlights the very real risks of cosmetic surgery.
Operasyondan sonra burnunun uç kısmında ciddi bir şekilde bozukluk oluştu. İkinci kez bıçak altına yattı ama sonuç daha da kötü oldu. Işığımı söndürdüler. İnsanlar bana öcü gibi bakıyor diyen Gülizar Aras doktordan şikayetçi oldu.
Dışarıya çıktığımda insanlar öcü gibi bakıyor. Bana maalesef.
Güzelleşmek isterken hayatı kabusa döndü. 2 kez ameliyat olmasına rağmen burnu bu hale geldi.
6 ay sonrasında tıpta da geçer adıyla papağan burnuna dönüştü. Bu nedenden dolayı düğünümü ertelemek zorunda kaldım. Çalışamadım. Yani tam
not just a Queensland problem, but a global issue that requires stronger legal and medical safeguards. To succeed in negligence, the plaintiff must prove that the surgeon's breach caused the harm. Under Section 11 of the Civil Liability Act, this includes 2 steps. Factual causation, Section 11, subsection 1, paragraph A, and scope of liability, same section, paragraph B. Did the surgeon's failure actually cause the patient's harm, and should the surgeon be held legally responsible for it? These 2 questions structure causation analysis in rhinoplasty case. The but-for test under Section 11, subsection 1 and paragraph A asks, but for the surgeon breach, would the harm have occurred? In Wallace and Cam, the High Court made this clear. For rhinoplasty, we can frame these questions like, but for the lack of psychological assessment. Would the patient have avoided surgery and mental harm? But for poor disclosure of hidden risk, would the patient have avoided infection? Or, but for the absence of simulation, would the patient have avoided post-surgery psychological distress? These questions show how causation works in practice. Sometimes harm has multiple causes. Section 11, subsection 2, paragraph A of the Civil Liability Act asks whether the surgeon's breach materially contributed to the harm. In Chapel and Hart, the surgeon's failure to warn about risk of infection materially contributed to patient's injury. Applied to rhinoplasty, even if multiple factors play a role, failing to screen or disclose key risks can still materially contribute to the patient's harm. In negligence law, it's not enough to show that harm occurred. We must ask whether it's appropriate for the defendant's liability to extend that harm. Section 11, subsection 2, paragraph B of the Civil Liability Act makes this clear. In rhinoplasty, for example, a surgeon's breach of duty must have a sufficiently close connection to the harm suffered, such as asymmetry caused by poor technique rather than complications that might have arising independently. There are also important defenses available to surgeons. Contributory negligence arises when patients fail to follow pre- or post-operative instructions, or when they withhold relevant medical history such as smoking or psychological conditions. Section 23 and 24 of the CLA provide for this. Another key defense is voluntary non-fit injuria, which means that a patient who gives informed consent, fully aware of the risk, may not later claim damages for those inherent risks. Negligence claims in cosmetic surgery are shaped by limitation periods and peer professional standards. Under Section 11 of the Limitation of Actions Act, personal injury claims must usually be brought within 3 years. However, extension may be granted if new decisive facts emerge, as seen in Rogers and Chinsey in 2024. Courts also rely heavily on expert opinion under Section 22 of the CLA, but opinions must not be irrational. Cases like Tabet and Gate highlights that plaintiff bear the burden of proving negligence on the balance of probabilities with 50%. In terms of damage, cosmetic negligence cases often involve 3 categories. First, physical injuries such as disfigurement, asymmetry, or infection. Second, psychological harm, including depression, anxiety, or worsening of body dysmorphic disorder. And third, pure economic loss. For example, the financial burden of revision surgeries or lost income from time of work. These broad categories show the real-world impact of negligence beyond just the physical outcome. Because the current legal framework doesn't fully address the unique risks of cosmetic surgery, reforms are necessary. Potential reforms include a no-fault compensation system, mandatory psychological evaluations, a new obligation for doctors to use simulation technology and provide outcome transparency. Together, these reforms aim to strike a balance between patient protection and fairness to medical professionals. Another important reform to consider is the introduction of a no-fault compensation system. This would allow rhinoplasty patients who suffer complications to receive compensation even when negligence can be proven, or when the surgery was performed overseas. Models like the RNS in the UK and ACC in New Zealand show that patients can access treatment and support without facing excessive time limits or long disputes. Such a system ensures that patients are compensated for unpredictable surgical risks, provides consistency across cases, and reduces the burden of litigation by focusing on patient welfare rather than blame. A key reform is mandatory psychological assessment before cosmetic surgery. This helps identify patients with unrealistic expectations or underlying mental health conditions like body dysmorphic disorder. By screening patients, doctors can prevent unsuitable individuals from undergoing surgery, which reduces harm and litigation. This is already recommended in the 2023 Medical Board of Australia guidelines, showing strong professional support. Another reform is the mandatory risk disclosure protocol. This would involve standardized consent form with clear checklist of both common and rare risks. Such a system protects both doctors and patients by making sure that the patient is fully aware of the possible complications before giving consent. It also prevents future disputes about what was or wasn't disclosed. Finally, simulation technology could play a transformative role by requiring surgeons to use preoperative simulations. Patients would gain a clearer picture of realistic outcomes. This reduces misunderstandings, ensures predictable results, and offers protection to both patients and doctors. It also makes it easy to establish whether negligence has occurred because expectations and likely outcomes are documented before surgery. In conclusion, negligence in cosmetic rhinoplasty raises unique and complex challenges. Establishing a duty of care can be difficult when doctors believe they have met standard disclosure. But as the High Court stated in Rogers and Whittaker, patients are entitled to high, patient-centered standards of information. When we turn to breach, failures in disclosure in hygiene or surgical technique, and particularly the absence of psychological assessment, can all amount to negligence. Patients undergoing rhinoplasty are often vulnerable, even small oversight can cause significant harm. Causation is also critical. The law requires that risks are linked directly to the surgeon's breach. For example, inadequate disclosure of rare complication or poor preoperative simulation can establish this connection. Without that causal link, liability is unlikely to be imposed. On the defense side, we must remember that some risks are inherent to surgery, such as infection or scarring, and these may limit liability. Contributory negligence is also possible if a patient ignored medical advice, such as failing to follow post-operative instructions. Finally, reforms are necessary to modernize the law and to protect patients more effectively. These include a no-fault compensation scheme to address unavoidable harm, mandatory psychological assessments to screen for conditions like body dysmorphic disorder, and the use of simulation technology to ensure realistic consent. Stronger disclosure obligation, including complication and revision rates, and binding professional guidelines would also provide greater consistency and accountability. Ultimately, the law must strike a balance between recognizing the realities of surgery and ensuring that patients are not left without remedies when things go wrong. Cosmetic surgery is not medically necessary, but its risks are very real, and the legal system must continue to evolve to reflect that.